Thank you, MT, and thank you to all the speakers. We covered really a huge range of difficult issues. We'll open it for questions now for the committee members initially, if we have more time. Terry, how much time do we have? Okay. I'm sorry, I did not do a very good job of keeping the order of who raised your panel, so I'm going to go straight down the aisle here. I apologize for that.
Thank you all for your presentations. They're very helpful. MT, one thing that we rarely talk about, the other little secret, is elder abuse from the older adult to the family caregiver. Can you comment on that, please?
It's really complicated, and it gets more complicated actually with cognitive impairment, where there are false accusations. You know, once again, we're in a relatively data-free environment. We don't know how much of it there is, and we don't know very much about it, but I think it's a really important issue. And also, like the flip side of the coin, you know, it's one of those issues where where it skates close to the edge a lot, because it's not clear to what extent is it disease, to what extent is it a pre-existing abusive relationship. All I can really say is we don't know a lot. It's really important, and it plays into it. And you know, as evidenced by the woman who does the sexual assault services, who's seen a lot of people who've been the victims of a lifetime of abuse, and actually the caregiving is just one more chapter of that abuse.
Laura?
My question was exactly the same. I just wanted to follow up just to clarify. Is there any data sources to look at prevalence?
No, you know, and I mean, I suppose almost nobody's funding research in this area. I mean, the National Institute of Justice at DOJ is one of the very few, and they just put out their most recent RFP. But, you know, NIA has funded almost no research in this area. It's one of these really unspeakable issues, and a lot of the big funders won't touch it. And it's part of it not being integrated into the mainstream of conversation, notwithstanding the fact that the prevalence numbers are outrageous.
Is Tara?
Yeah, thanks to all of you. I have a question for Nina around decision-making and decision support. Just based on the fact that we know that in general, humans are not optimal decision makers. They don't always understand options, probabilities, or in the case of a surrogate, what their responsibilities are as a decision maker. And you talked about the need for providing decision support, and I wonder if you might expand on if you have ideas or know of strategies to do that with caregivers and with patients, especially when they're in a stressful situation, as many of them are.
Great question. So there's a big push right now to move away from surrogate decision-making to supported decision-making, right? And this idea that instead of taking the decision away from the individual, you help the individual make the discussion. And in fact, supported decision-making is part of the law in a number of countries and may soon be the law in states here. The problem is once again, we're in a fairly data-free zone in that there's a lot of talk about supported decision-making, but when you unwrap that discussion, there's virtually no research on what does that look like and what practices actually work. So, you know, we can learn something from the literature on communication and how people make decisions. You know, as an informal matter, it's about bringing people information, helping them work through and process that, some reality testing. But I think a big part of moving into that new paradigm of supported decision-making is this first step of figuring out what does good support look like. Because right now we're just saying, go support people, right? And does that simply become whitewashing, making decisions for people without even the accountability of, say, guardianship, although that's minimal too.
Carol, I think you're next.
Thank you for your presentation. You've given us a number of ideas about identifying situations. Who or where would you see this identification taking place of potential elder abuse?
Well, I mean, I think if we educate families about thinking through who might be the most appropriate caregiver and why, discharge planners, care managers. I mean, I think it should be part of the coordinated care management conversations. Eric Coleman's kind of care transition, those provide opportunities to assess what makes sense. I mean, it's helpful to have better information about what makes sense, but some stuff is kind of intuitively obvious too. And then actually, I said it's a data-free environment and I stand by that. We have a little bit of information about correlations and stuff like social support and isolation and dementia and, so it's some correlation. So, don't get isolated, plan, think about who you trust in advance. And then, going to Nina's side of the fence, figure out which kid is actually, or which potential family member is going to be the one who's going to provide the decision-making that's in greatest concert with your own. And so I think a lot of it is planning in advance to think, okay, don't wait until it's too late to make these decisions. And again, to make it part of the contemplation, things can go wrong and do go wrong, so how do you avoid it?
Okay, I have Donna, Richard, Terry, Jennifer, and Karen. So, Donna.
Thank you all for your presentations. I have a question for Cynthia. Cynthia, I know that you're a lawyer, and everything isn't always, every problem is not always solved by the law. But I'm wondering if you have any, this is going to put you on the spot a little bit, but if you could do one thing, one policy change to help reduce family caregiving discrimination, what might it be?
You're right. Not everything is solved by the law. And when I'm working with employers and employees, the first thing we try to do is work through what's going on in the workplace, work on interpersonal relationships, work on bias as it arises. I can't tell you one thing that I would change, but the one thing that I've seen that's made the most difference is bias training within organizations, because that not only can address what's going on in between the individual supervisor and the employee, but it also helps to make organizational change so that there's more support for caregivers. One of the things that we try to do as part of the training is have people take a longer view rather than the short term, someone's going to be gone for 4 months or they're going to be gone every Friday for the next 6 months. We take the longer view of what's that person's career going to be like and what contributions has that person made to the organization, what contributions will that person make to the organization, what are their relationships with customers and clients, what are their institutional knowledge. And then when you start looking at the real value of the person in the long term, you start to reduce the bias against caregivers in the short term.
Richard?
Talks. This is a question for Cynthia again. It would be very useful for this committee to have data on prevalence rates of elder abuse or elder care cases or any other kinds of cases that might be relevant to what this committee is looking at. So are there national databases that we could look to that would give us some sense of how often these kinds of things are appearing?
Yes and no. There's one, which is maintained by the Center for Work-Life Law, and we will be issuing a litigation update in the next couple of months, and that will include a section on discrimination cases brought by employees who care for elderly family members. The problem is that doesn't give you a complete handle, because one of the things that we know is only a very, very small fraction of the discrimination cases end up in court, and then those cases end up in the database. One of the things that the Center for Work-Life Law does is it runs a hotline for employees who think they might be facing FRD. And out of the first 1,000 phone calls that we got from people, I would say maybe about 20 of them ended up in charges that went before the EEOC, and only 3 or 4 of them ended up in court cases. So the problem is going to be much more prevalent than what's suggested by the cases that will be in the litigation report. Just to give you a little bit of an idea, right now we have just over 4,000 FRD cases in the database, and I believe we have just under 500 cases that involve caregiving of elders.
Terry?
Thank you so much. Great panel. I was thinking, as you were all speaking, and particularly MT, related to adult protective service workers, a large workforce out there, and any ideas you might have about how we get a better engagement with our APS workforce with family caregivers and systems of care. They're a big workforce. They are relatively invisible, I think, in the caregiving conversation. So any thoughts you have on that?
Wow, what an interesting question. I mean, they're also invariably overwhelmed, especially as state budgets cut back on them and are, you know, often it's a kind of an oppositional relationship in the cases that they go out on. I mean, I would say integrate them more into the conversations about family caregiving at the policy level would be a really important thing to do, because they have a different kind of perspective than most of the rest of us. But I think, you know, and at the national level, I think that would be something that maybe some of us could work on. And I had one other follow-up to a question I got earlier, if I may. Now, I think one of the things that has gone missing is that caregiving is a really important public health issue, as is elder abuse. And we've recognized it with child abuse and domestic violence. We've not recognized, I think, caregiving as, and sort of when it goes off the rails, as a health issue sufficiently, and it should be part of the conversation with health providers. You know, so a woman who's 65 goes into the rheumatologist, has bad arthritis, and is the caregiver for her 95-year-old mother. Like, how's that going on either side of the equation is at least as important as a lot of the other questions that you might get about health. And then also for financial institutions that are increasingly beginning to engage these questions, because they're really complicated, and the financial issues in terms of what crosses the line for caregivers is really tricky too. You know, like, you're going to get dad's groceries and you're the caregiver. Is it okay to buy your own? I mean, that's a very minor question, but the questions get much bigger too. So I think, you know, there are a lot of different points of entry that could be engaged more into the conversation. And a lot of people are family caregivers, so they get it. And they're going to be receptive, I think.
Jennifer?
Thank you for a terrific panel. My question is also to Nina, following up on Sarah's question about your slide on opportunities for improvement around supportive decision-making. And in particular, I was really struck at the beginning of your talk about the importance of decisional capacity across a range of domains, including financial decisions, legal decisions, decisions about lifestyle and housing, and as well as healthcare. And I guess my question is, do the model ideas of supported decision making now happen anywhere, and if so, and who do you envision supporting individuals and family members in making optimal decisions? And so do you envision this being something that physicians would do, or nurses would do, or social workers would do, or does this occur outside the health system, and who's responsible for paying for it?
Okay. So the supported decision paradigm really grew out of working with younger individuals with developmental disabilities and intellectual disabilities, and recognizing that many of these people were being pushed into guardianship and very rights-limiting models, and that they had trusted others in their lives, that if you allowed a little more time for decisions and recognized those relationships, the individual with the disability could make decisions for themselves. And so really what this model has come from is largely parents, of young adults with developmental or intellectual disabilities, and that's been the supporter, right? And so part of, I think, the challenge in thinking about bringing supported decision-making into decision-making for older adults is how does that translate into the types of caregiving and family relationships the older adults have. The notion is that the supporter would be a trusted other. Part of my problem is I spend way too much time in MT's world, and the notion of relying on trust is very concerning. So this is the supporter would be an individual of the individual with the challenge, choice. But the question is, how is that choice made? How freely is that choice made? How informed is that choice? Does the individual feel like they have a choice in selecting the supporter, and so forth? So I think we can learn from the shared decision-making model in the healthcare context, but supported decision-making is really about, in some ways, formalizing informal familial or friendship relationships. Does that answer it?
I think the last question will come from Karen.
And my question is for Cynthia Calvert. You mentioned training supervisors and HR, and for that to take place, the training relationship must be initiated. So I am assuming that the need for training is greater than the implementation, actually, of training relationships. So what can you advise us about the most effective ways to initiate training relationships, especially when the trainer is external to the organization where training would take place?
That's certainly one way to do training, is to bring someone in from the outside. Another is to train HR people to provide training within the organization. That's something that I've certainly done. People are also looking at online training and other ways to provide sort of some education. One of the things that I'm looking at right now is a model of informal training in which people model behavior within the organization. When they see bias, they challenge it. They are alert to the situations where the bias is likely to occur, that discrimination is likely to arise, and they act preemptively. So that's not necessarily training. It's more informal, but I think it has potential to be very effective. Right now, I think one of the biggest hurdles is just getting employers to understand that they have this problem. One way to do that is publicizing the verdicts that the employees are winning, and that's something that Work-Life Law has done. Another is, you look at the business case and you start putting some dollars to the loss of valued employees because of discrimination, and you compare it to the productivity of keeping good trained people of institutional knowledge and good relationships. So those are a couple of different approaches, but that really is the first hurdle.
Okay, so for the open mic, do we stay up here or do we?
Welcome, stay up there, and Rich is going to moderate,
Okay.
and we'll ask our speakers to come to the podium or make sure that you come to a microphone at least. And so Rich will take over. Yeah, absolutely. Let's applaud the panel.